Yes, the results of ATLAS and FLAIR clearly supports the use of long-acting cabotegravir and rilpivirine as monthly intramuscular injections, but there are still challenges on how to implement this strategy in our clinics. So the first one is, who are the best candidates for these therapies? At first sight, it might seem that poorly adherent patients are the best candidates for these medications, because when you inject them, you have covered 1 month or perhaps 2 months when the ATLAS 2M results are released. But there is something very important, that the patient has to come back to the clinic for the next dosing. So you need a safety measure to guarantee that the patient comes back, because if he doesn't or she doesn't come back, there is a long tail of elimination of these drugs, and there is the possibility of resistance. So that's challenge number one. Number two is that we work in Europe in very busy clinics, and right now with oral therapy, patients come to the clinic every 6 months. If they have to come back every month to the clinic for the IM administration, that will put more stress in clinics that are already busy. And working in a national public health service, the other issue is going to be cost. We are in the era of generics, and we have cheap generics that are oral, so still we have to see how we are going to handle the issue of cost. So those are the three big challenges right now with monthly intramuscular injections. So is the issue of the long terminal half-life of these combinations is very important, both for treatment and also for prevention. For treatment, we have a window in the trials of 2 weeks for the patient to come back to the clinic for the next dosing, but if the patient does not come back, they need a backup regimen. And with cabotegravir and rilpivirine, it's nice that we have the oral formulation of these drugs, so if for some reason the patient cannot come back to the clinic, he or she will be able to take the oral medication to cover for this long tail. Yeah, in PrEP, this issue is also very important, because you can detect this drug after you stop cabotegravir, for example. You can detect it up to 52 weeks after stopping the drug in a proportion of patients. So we have to cover that tail also with oral medication. So that in the trials is going to be also an issue, and the prospect is that we have to cover with oral medication. So this is definitely something that we have to take into account for this strategy. So the next step in research for long-acting is obviously try to give it even more infrequently. Also, what is coming relatively soon is the data from cabotegravir and rilpivirine every 2 months instead of 1 month. So, but there is a pipeline of long-acting drugs that are looking also at other ways. With this drug, MK-8591, there is the possibility of giving orally once weekly. And still, we don't know what is going to be the partner of this drug for once weekly. And there is this new family of drugs, the capsid inhibitors. The first compound, we've seen data at CROI that can give in healthy volunteers subcutaneously, and giving it, we've seen the pharmacokinetics that probably allowed to give it every 3 months. So, and there is the issue also of implants. With implants is the possibility, at least for some drugs, to be used with these implants every 6 or every year, 6 months or every year. But again, we need to find the partners for these drugs.